recording there. It should be okay. There we go. Whoops, where did my slide go? There it is. Okay. All right, so we're going to talk today about lumbar radiculopathy. So this is one of the, and this is a little bit interactive, a little bit presentation. This is kind of one of the more common conditions that I see when I'm doing EMGs. You know, it depends on your clinic and what your referral base, what your patient population is. But in certain areas in New York City, we see a lot of patients with radiculopathies from spine surgeons, from orthopedics and things like that. So it's one of the more common conditions that I encounter. So I wanted to talk a little bit more about this. Laura and Roy, where are you? Do you see a lot of patients with radiculopathies in your practice?
Yes.
Yeah, we definitely see. Yeah.
Okay, cool. So this will be this hopefully will be helpful for you. We'll go over some, a little bit of basics and some little challenging things, and there's some interactive stuff where you guys will. I'll ask for your feedback and see what you think on some of the situations.
All right.
We'll start off with the case. This was a 43-year-old male. He was injured to the low back while at work, and this is another common referral. Whoops, what did I do? Sorry. This is another common referral in the workers' compensation population. Since the injured back, it was a couple of years ago, but the pain that he experienced was gradually increasing to the low back and bilateral legs, with worse involvement on the left. He described unstable, so weakness, with ambulation and kind of foot drag, not necessarily foot slap like in the case of complete paralysis of the muscle, but he felt unsteady on his feet, like he was losing his balance. So he started walking with a cane. He had an MRI test done, which is helpful sometimes. And the MRI showed that the lumbar spine, this was the report from the patient. You can get to view the images myself or the report, but he said there was disc disease at the L4, L5 level, and he was certain of that. The pain was intense, about 7 out of 10. And in the L5 S1 dermatome, left leg and lateral part of the foot, describe it as stab, burning, and numbness. And now he came into the office for EMG evaluation of the lower extremities with the rule out diagnosis of L4, L5 disc disorder. So the physical exam, there's the findings in the physical exam. He complained of decreased sensation to light touch, and he had evidence of decreased sensation to light touch in the entire L4 through S1 dermatome. So a little bit confusing presentation there, and bilaterally. Manual muscle testing was fairly normal, maybe a little bit weak, about 4- to 4+ on both lower extremities. His reflexes were normal. And those are the basic big three screens. If you're going to do a physical exam screen, obviously if you're doing a PTA evaluation, you'll do a lot more. But in a physical exam for EMG, you kind of want to get the big three of the sensation, the manual muscle testing, and the reflexes. So not too much helpful there, but we're still thinking along the lines of radiculopathy. Provocation tests, they were negative for Tinel's at the ankle, but he had positive Tinel's of the peroneal nerve on the left. So that's our first little curveball that we have a little thrown in here. Straight leg raise, as in most people with back pain, is positive anyway, so it's positive bilaterally. He had edema around the ankle, so that made the test a little bit harder, and his functional status was ambulation with a cane. So based on those presentations, what do you think, kind of self-explanatory, but what do you guys think are the primary differential diagnoses that are going on through your head as you're looking at this patient?
Well, definitely a lumbar radic, possibly a focal, something going on at the fibular head on the left. But, obviously that would have to be investigated further with testing.
Right, yeah. So those are pretty straightforward. Those are correct. that, and the differential diagnosis, lumbar
John?
Yes. Mm-hmm.
Do we have any indication from the patient of obesity and significant weight loss over a short period of time?
No, this patient didn't have any fluctuating weight changes. Like I say, he did have a little bit of edema in the ankles, but there was no significant like weight loss or weight change in the recent history.
Okay. Now, Roy and Laura, do you guys know why I'm asking this specific question? Laura, can you elaborate?
Yep. Well, with peroneal neuropathy, that's a common occurrence with somebody who had weight loss, because with the weight loss, now the peroneal nerve is a little bit more exposed around that fibular head because it's used to being so much more, girth around it, and then they lose weight and peroneal nerve becomes more exposed, and then they cross their legs because they're not as heavy, and then they get the compression on that peroneal nerve around that fibular head. That's one of the reasons why I thought,
Good.
Okay. All right. So the differential diagnosis again, lumbar radiculopathy again, through anywhere from L4 through S1. The clinical exam wasn't too helpful in just differentiating. Maybe perhaps L4, L5 is in the back of our mind because of the positive imaging studies. And we also have to consider as a secondary the peroneal neuropathy on the left. So those are our two main differential diagnoses. So the plan for what kind of tests, when we have our differential diagnosis, the next step in the process is to develop a plan as far as what we're going to do specifically for this patient to address the issues and to answer the questions as to what we think the person may have. So, Roy, do you want to give us your plan as what you would do with this patient, like what nerves you would test and what maybe muscles you would target first?
Well, I mean, I think we're still going to go look at the peroneal and tibials and sensory and motors from the standpoint. Trying to think from there. Let's say we could certainly do some F-wave, make sure from that standpoint. And I'm just trying to think as far as, working as far as our EMGs. Let me think. See, I've only gotten one here, John, so I might need a little help because I haven't gotten that far as far as the low. But
okay. All right. Is there any so the peroneal, the tibials, those are good. Those are the kind of bread and butter default ones. Those are definitely indicated. And the sole and superficial peroneal, those are also indicated with the areas of numbness, and those are some of the easier ones to get in the leg. They're usually not the ones in the legs usually aren't easy to begin with, but those out of all the sensory tests in the lower extremities, those are the easier ones. Anything else? Is there any F waves is okay too, but what is one thing that is missing that is really, really effective in radiculopathies, especially in the lower extremities?
H reflex.
The H reflex, exactly. What the H reflex is very important to add because it helps to look at the speed or the myelin integrity of the entire nerve pathway, but also of the root level. Because we don't most sensitive test that we have in nerve conduction is measuring the speed across a given segment, how fast the nerve is traveling. And a radiculopathy is basically just a compression injury that happens at the root. So the same pathophysiology happens where the injury presses on the nerve, it presses down to the myelin, it compresses the myelin, makes it travel slower, and then eventually as the compression worsens, it can damage the axon. So in this case, the H reflex, which was measuring the speed across that segment, particularly the S1 segment, is going to be abnormal first than if there was axonal damage. So this would be, that's why the atriplex is so helpful in lumbar radiculopathies, even if it's not the level of suspicion, like if not S1, it can help because it can help to rule out S1 if S1 is not positive. So what about, Laura, do you have any suggestions on muscles that you would check in your EMG muscle exam?
I would definitely do the VMO. I would do short head of the biceps.
Mm-hmm.
I would do anterior tib. I would do peroneal. I would do posterior tib.
Mm-hmm.
I would probably do. I may or may not do a foot if foot muscle, just to narrow down possibly the S1, like possibly like I don't know. I could do the abductor hallucis or the EDB.
Right.
Um,
Well, those muscles you mentioned are good. The foot, I sometimes tend to shy away from the foot. One, for a couple of reasons. One, because it really hurts.
it's very painful, yeah.
The smaller the muscles, the more painful they are. So they really can be uncomfortable. The foot muscles tend to get damaged, from wear and tear.
But I would definitely do gastroc too as well.
Right. Yeah, that was the one I was thinking. That's another really good S1 muscle that can be really helpful. You did mention there's some S1 muscles like the tibialis posterior. Those are other good S1 muscles that can be checked to help measure that. You want to get a general, which you did. You want to get a general sampling of muscles, 2 muscles per root level, and through the 4 through the 1. So, and that's a generally good screen. So that's generally what you want to do. About at least 5, maybe 6 or more muscles, getting at least 2 from each nerve root level. Good. All right. So let's take. Yes.
Can I mention something here?
Sure. Mm-hmm.
2 things. One is, if I remember correctly, this is John. You said there was bilateral symptomatology, right?
Yes. Mm-hmm.
Okay. Now, the comment I'm gonna make does not necessarily apply in this specific situation, but whenever you have a bilateral symptomatology, especially when your EMG will not be perhaps 100% clear in its findings, one of the things that you may want to do is somatosensory evoked potential studies, which can be one of the indications for them are bilateral symptoms that can be due to myelopathy. Myelopathy can occur in some cases even with a broad large herniation that can compress the cord and can lead to various other symptoms, but bilateral numbness, tingling, weakness can be an indication. Now, obviously, your late responses, as well as, when I'm saying late responses, Roy, you get what I mean?
No.
Okay. So
I can, if you want to end, I can end, or you want to take that. The late responses, they're named simply stating because they take a long time. Basically, they're just the responses that measure the speed of the entire pathway. So they take a long time because they're measuring and they're measuring the speed of the entire nerve segment from when you stimulate distally up back to the spinal cord level and then back down to the muscle. So
Right.
those are the H reflexes and the F waves. Those are the typical responses.
Yeah.
Got it.
So your late responses, right, along with your needle EMG in the paraspinal musculature will give you an indication of the anterior horn cell of the spinal cord. But when you are talking about the dorsal horn, that will not be evaluated neither, of course, by the EMG nor by your sensory studies. So somatosensory evoked potentials is your only means in this case to evaluate that dorsal horn of the spinal cord and its ascending pathway. So it could be one of the indications for SSCP testing. So that was one comment. And then my question and challenge, John, is where do you see the importance of F-wave studies in this specific case?
Well, F waves generally are very helpful to help rule out polyneuropathy. That's the biggest value that they have in what I usually test is for polyneuropathies, because they're measuring the speed of the entire segment, so they can help to look at the overall speed of the nerve. In the lower extremities, the commonly done are the most common. You can theoretically do an F wave from any nerve, but the two ones that are commonly done are the peroneal and the tibial. And the peroneal tends to be a little bit challenging because the muscle itself is so small. But the tibial is fairly reproducible. But it measures the motor nerve pathway, and the H reflex is measuring the sensory and motor nerve pathway for the tibial nerve. So the F waves are very helpful in ruling and helping in the evaluation of for a polyneuropathy condition. Did I lose everybody?
Yep.
Nope.
Okay.
That's good.
Okay.
So hi guys, I'm sorry. Thank you.
Okay.
Sorry if I get.
Okay. Yeah, I forgot to mention on the slide, but his history was normal. He didn't have any significant medical history. I forgot to include that. But his significant medical, he had no indication of significant medical history. It was normal. I forgot to include that, so shame on me. But yeah, that's definitely something to include in the workup. So there's some of the data. So I took out the any possible highlights. So when we look at the data, again, just to review, we want to look at there's a bunch of numbers on the screen, and we want to look at mainly three major categories. We want to look at the onset latency, or the distal latency of the latency of the distal segment, the amplitude of all the segments and of all the nerves, and the velocities across each different segment. So we do a general screen of the data, and we compare that to a norm, and we look at and try to identify what's potentially abnormal. So looking at the data here from the nerve conduction studies, does anything kind of jump out at you? Is there anything that's kind of jumping out and screaming at you, saying, take a look at me, what's going on?
Not really. Let's see, velocities look good. Amplitudes, well, popliteal. No, let's see. Here, 7.2, that's good. If I look at amplitude and velocities, they don't look bad.
Okay. All right, so pretty much for the most part, mostly
Yeah.
looks pretty good.
Yeah.
Those three columns, the distal latencies of the ankles are all within normal range.
Right.
The amplitudes are all above the norm, and the velocities are all above the norm. So everything is checking out to be pretty good. Okay, and that's typically what we expect in a radiculopathy, is that the velocity, that the nerve conduction studies, motor and sensory for the most part, are pretty much normal, unless it's some kind of multi-level type of disc pathology. Then we look at the sensory nerve conduction studies and the late responses. And we look at the sensory nerve conduction studies. I didn't include the velocities, but they can be looked at also. I included just the amplitudes and the peak latencies for the sensory nerves. And for the H reflex, I looked at the overall norm and the left to right comparison. And we can see here that obviously the big thing that jumps out at us now is the H reflex on the left side, which was the more symptomatic side, was unobtainable. There was no response.
Right.
So there's no response. That could mean axonal problem. That could mean, you know, a very severe conduction block. We need to do a little bit more digging to try to find out, you know, where the problem may be. So we kind of look at, see the findings here that, okay, we have one positive finding, definitely, that we have the H reflex on the more symptomatic side as being abnormal. Anything else kind of jump out at you, Laura? Anything else that you kind of look at and take a second peek at, or you know, take a second guess at, or
Well, I'm just looking at the amplitudes on the right superficial peroneal sensory is 18, and the left one was 8.1.
Okay.
So there was a like 50% loss in amplitude.
Okay.
In the superficial peroneal on the left compared to the right.
Okay.
And I saw an amplitude difference too in the motor study too at the popliteal.
Right, we did see a little bit of a drop. It's still above normal, but we did see a little bit of a drop.
Little drop from the motor.
Peroneal amplitude did drop a little bit as well. That's correct.
Right.
All right. So now we can progress on to the EMG part of the study. We can progress on to the EMG part, and this study took a little bit of time. You don't have to do all these many muscles. But this is, you know, standard data table, and I this time I colored in some of the things that tell us different parts of the picture. So for each one of the muscles, the beige columns are the resting potentials. That's where we see if there's spontaneous activity going on, and spontaneous activity is usually a sign of active denervation or acute denervation. That's a sign that there's a disconnection that's actively taking place between the axon and the muscle. So that any abnormal findings in insertional activity, anything where we see fibs or positive sharp waves, those indicate that there's active denervation going on. The red column, which is the motor unit analysis, that's where we look at the shape, the amplitude, and the duration of each individual motor unit. So they tell us they give us information about the chronicity of and they tell us that the injury is a more chronic based, because if the motor units are changing, whether they're changing and getting bigger or smaller, whether they're getting more wider or narrower, or they're getting a multiphasic, that's a sign that reinnervation is taking place, or regeneration, or collateral sprouting. So those are signs that the injury is more in of a chronic phase. And then the final two columns, which are highlighted in yellow, are the muscle activation pattern, which are the recruitment pattern and interference pattern. And they give us an indication on how well the person is able to activate that muscle. So how well that person can go from a minimal contraction all the way to a forceful contraction. So they each give us a little bit different piece of the puzzle. So we can see here that I added a few other muscles that we didn't mention. The adductors, they're a little deeper. You need a little bit longer needle, but you can still get them. And they're another good L2 muscle. There's not too many L2 muscles or L3 muscles that we can check. But the adductor longus is one of the easier ones besides the VMO. So I added that one in there. And some other muscles as well. But the right leg, which was the less symptomatic leg, checks out all the muscles. Obviously there was normal. Then we progressed to the more symptomatic side, which was the left side, and this is just the same column, just a different type. And we see now we have a lot more abnormalities. We have, the EHL nothing is spontaneous. There's no active spontaneous potentials going on, which kind of matches up with our time frame of injury. Remember, the injury took place 3 years ago. So the injury took place 3 years ago. So we're not seeing any active denervation taking place. However, when we looked at individual motor units, we saw that some of the muscles had increased polyphasics, such as the EHL, the anterior. You're not going to read them all, but you can take a look at it there. Some of the muscles had increased duration, like the anterior tibialis, the peroneus longus. Some muscles had anywhere from a severe decreased recruitment and interference to a mildly decreased recruitment interference. And that's kind of a subjective term as far as what's, how decreased it would be. But compared to the tibialis posterior, the other muscles like the EDB and the peroneus longus, those were severely decreased. So you can see some of the findings there. So basically, we have most of our findings so far indicate abnormal EMG with some possible subtle NCV findings. So the summary of findings is just kind of regurgitating the data table. It's regurgitating the data table into Word format. And the machines can be helpful in generating this based on how you program the machine, and based on the normal values that we put into the machine. All the test results came back pretty much normal. Normal latencies, normal distal amplitudes, normal velocities. For the most part, the NCS is checking out normal, with the exception of the H reflex. So we had no response obtained with the left H reflex latency. So that was the summary of the nerve conduction studies. The EMG obviously is a little bit more profound. We had a lot more. We had, as I mentioned, increased amplitudes of many of the motor units and all those muscles listed. We had increased duration in a few of the muscles, and the muscles, they aren't kind of the pattern of abnormality is not within a particular nerve, because there's muscles innervated by the peroneal nerve there, and there's muscles innervated by the tibial nerve. So we can't use that as a qualification. It's not the pattern that the abnormalities are fitting into are along a root pattern. The specific root is so far looking to be majority of the S1. There's some L5 involvement, but there's majority is being S1 nerve root involvement. We also showed that we had reduced recruitment and interference, and then severely reduced recruitment and interference in the left EHL and other muscles there. All the other muscles tested were normal. So based on the findings, what kind of impression do you think? What kind of interpretation do you think this person is presenting with? What type of condition? How would you word this? Or how would you describe this condition?
Chronic L5S1 radiculopathy.
Okay. Anything else? Anywhere? Any other descriptive terms? That's correct so far. Help to describe it.
Just trying.
Well, let's see.
One subtle thing that you're missing, but it's a little important to mention. You said chronic S1 radiculopathy.
Would you say L5S1 or would you say S1?
Well, so far, the reason why I would say S1 would be because
of the H reflex.
Because of the H reflex, yes, the H reflex is leaning me towards the direction of the S1. Okay. So I would go with that. But what I was looking for was left. That was the you wanted to.
Oh, yeah, left. Yeah, sorry, I meant to say that.
Yeah. That's simple, but it's it's simple but important. But obviously all the findings on the left side, so we want to say it's on the left side. So good. Right. So looking up pretty good. So we have abnormal study. There's currently significant electrophysiologic evidence of a moderate to severe. It can be argued how you describe severity for radiculopathies, but moderate to severe, or even severe, those can be argued. Chronic motor axonal compromise of the left S1 nerve root. So it wraps up in a nice big easy bow, right? Everything looks good?
Yep.
Well, not quite. There's more, but wait, there's more. There's a couple questions we didn't ask. So some of the questions is, why would a disc problem at the L4, L5 level? Remember, we did have the positive findings of the herniated or disc disease at the L4, L5 level, but our test is showing S1. That doesn't match up, and this is something that I work with a lot of spine surgeons, and they kind of sometimes can't grasp around that a little bit too much, as far as, well, the MRI shows one thing, but our EMG is showing something totally different. So it doesn't add up kind of a little bit. But we also did mention, if you had an S1 radiculopathy, that really wouldn't cause the findings in the anterior tibialis at all. Anterior tibialis only has L4 and L5. So an S1 radiculopathy wouldn't cause any findings in the anterior tibialis. The EDB and EHL they do have some S1 components, but they're predominantly L5. And why were the findings worse in the peroneal nerve muscles? So these are kind of questions that, we have the data, we have our findings, but these are some kind of things that make you take a second guess, and we didn't really address those questions. Those are questions we need to still look at. Mm-hmm. So as far as the disc issue, two pictures are really helpful. I like referring to these pictures a lot. When I talk about the spine, is that it's important to note that the below the L1, L2 disc space is where all the else is chorda equina. Mm-hmm. So depending on the direction of the herniation or the location of the injury, it will affect different nerve root levels. So on the left side of the screen, this is a picture taken looking down at the L4, L5 disc space. And we can see that if something herniates posteriorly, it will push upon directly posterior the very low nerve root levels of S2 to S5. Then as you traverse more laterally, then starts to match up with the level of the root level itself. And then the Netter book, which PT students nowadays don't even use that book, and I can't believe it. I live with that book in PT school. The a medial protrusion at the L4, L5 space affects either mostly L5 or even S1 through S4. So because of the chorda equina orientation. So that's why a lot of times the structure may be present at the L4-5 injured at space. That's where they would do the surgery, but the function of the nerve is taking place at the S1 level. So a surgeon would go in, and if it comes to that, a surgeon would do maybe epidural injections or whatever they would want to do, at the L4, L5 level. But physical therapy speaking wise, we want to address more of the S1 level, more of the S1 nerve root, more of the S1 muscles when we're strengthening the patient. So this is why the EMG is a very good functional test, because it measures not the picture, but it measures the function. So that kind of explains that question. But we need to take a little closer look, and we need to look at the NCV, because maybe that doesn't answer all of our questions. So you guys were pretty sharp on the ball, and you kind of answered a little bit of my questions before, but we talked about briefly, and I kind of glossed over because I don't want to go over the answer now, but we do have that drop in amplitude. We have that drop in amplitude from the below fibula segment to the popliteal segment of an amplitude of 6.3 to 2.9. So we have a significant amplitude drop from one segment to the next. Now, generally, the rule of thumb is about 30% in the lower extremities from one site to the next. Depending on what source you may read, some sources may even say at the 50% or as low as 20%. But generally, maybe about 30% in the lower extremities is usually acceptable. But in this case, we're definitely way below that. So we're definitely have some abnormal finding there. We have, we went from 6.3 down to 2.9. And the machine didn't pick it up because we didn't program. If you look at where we have our norms, we have a norm only at the distal segment. We only have a norm listed at the distal segment. We didn't have a norm listed at the other segments, so our machine, unless we programmed it to do so, would not be able to pick that up. So you always have to, look at the data as a whole and not just go by what the machine is giving you. And then the other, you also stole my thunder here, but we look at the comparing the amplitudes. And we see that there is definitely a side-to-side difference of the superficial perineal sensory nerve on the right compared to the left. Again, they're both above the norm. Norm is 5 in this case, but we have a difference from 18 to 8. So we have a significant amount difference, and for limb-to-limb comparisons, usually is about 50% is the acceptable range between contralateral sides. And this is obviously above 50%. So we have some more findings to discuss. So, and this is one of the colleagues, Greg Ernst, he talks that dogs can have ticks and fleas. So patients can have two things wrong with them. So patients can have radiculopathies, but they can also have something else which could be causing even more symptoms and more findings. So our impression is continued. So we have another impression that there's also significant electrophysiological evidence of a moderate, again, severity is debatable, compromise of the left perineal nerve at or about the fibular head, involving the axonal components of the motor and sensory nerve fibers. we have abnormal sensory and motor amplitude, and we have abnormal EMG. So that indicates axonal damage. Is that right?
Mm-hmm.
Yes.
Okay, well, not quite. Not all the time. This is one of the things that people may fall into a trap a little bit, is that most of the time, abnormal EMG and abnormal nerve conduction amplitudes would indicate axonal problems, but not all the time. If you see on the nerve conduction study that the distal amplitude is normal, that means that the distal axon is intact. If the distal axon is intact, that means that the entire axon is intact, at least from what nerve conduction studies tell us. EMG is more sensitive at detecting axonal damage, but if the distal amplitude is intact and normal, then the entire that means the distal axon is normal, so that the entire axon is normal. Because if the axon was damaged at the perineal, let's say in this case the axon was damaged at the fibular head, which is also correlates to his clinical symptoms. We had that positive Tinel sign at the fibular head. If you damage the axons there, then the axons would be damaged distally as well. So we reduce response of the perineal motor nerve, which wasn't the case. If we go back and look at the distal amplitude, we can see that it's even higher than the less symptomatic side. It's 7.2. So it's actually preserved quite well. So what caused this this abnormal amplitude? And we also saw that we had recruitment and interference, and they all don't always indicate axonal damage. Those are, remember I said that when we're looking at the EMG table, the recruitment and the interference, they're measuring how well the person can contract the muscle. Mm-hmm. If the person doesn't want to contract the muscle, then you're not going to get any interference, or you're going to get reduced recruitment and low interference. If the person is something, if I step on your nerve, and think of the nerve as like a garden hose or a straw, if you push on it and collapse it all the way, even though you may not damage the material of the straw, if you compress it to enough degree, the fluid inside the straw is not going to get through. So the signal won't get through, so the person won't be able to contract the muscle. So we have to look at, and in political's day and age, I'll throw up a JFK there, we look for the right answer, not my answer, not your answer, but we look for the right answer. So this was an abnormal study. Again, we ruled in with our EMG, ruled in that you have a chronic motor axonal compromise of the left S1 nerve loop. But we also have electrophysiologic evidence of a moderate partial conduction block. So this is the key that we have to identify, is that this is a conduction block. This is a myelin injury of the perineal nerve at or about the fibular head, involving the sensory and the motor nerve fibers. Because the motor units, they were pretty much the same as the other non-S1 muscles. It was the recruitment and interference pattern that showed more EMG abnormalities within the perineal nerve distribution than the other nerves did. So this is a classic case of a conduction block, which is a myelin injury. It's a bad myelin injury. It needs to be addressed and has better potential for improvement with immediate intervention, because it's only damaging the myelin, but it's important that we identify that this is still a myelin injury. So this case ended up being having two problems. One, which was long-standing, from possibly, you can't rule in for sure, but possibly the work injury because it's chronic. And then we also have a not determined. We can't determine the chronicity of it, but we definitely have a myelin injury, a second myelin injury, which of the peroneal nerve, which could be causing and is likely causing his coagulation deficits. Because if you cut off the supply of the peroneal nerve of the fibular head, it's going to knock out your anterior tib, your inverters during the swing phase of gait, which is why he's reporting so unstable gait. So the take-home messages of this case is that, again, the nerve conduction EMG gives us a functional report of the nerves. It doesn't look at the anatomy. The anatomy is looked at by our imaging studies. In this case, the MRI was helpful. In the joints or the extremities, obviously ultrasound is very helpful as well. To look at anatomical deficiencies and anatomical deficits, but especially in the case of the lumbar spine, the imaging studies will not always match up and correlate that well with the EMG studies because of the orientation of the nerve roots in the spine below the L1 level. Make sure that you're able to not only look at just what the machine is telling you is abnormal, but always go back and review all of your data and look for things that don't quite make sense. Look for, amplitudes that drop quite a bit. And look for, side-to-side comparisons, which the machine may not detect. To kind of try to find, to answer the complete picture. And then the other thing is that EMG, while most of the time is measuring the axons, except in the case of recruitment and interference, that's also giving us information about the myelin as well. So, in this case, it correlated highly with the clinical symptoms and correlated with the drop in amplitude, that the peroneal nerve injury was in fact a myelin injury, which is a better prognosis, which means that the patient has better potential to improve with quicker intervention.
Got it.
So this was kind of a half textbook case of, but also half half curveball case as far as additional presentations where a person may, when you're doing the test, you may have one thing in mind, but then you go on and you consider and look at the data as a whole, and you're able to detect something else that maybe was in the back of your mind or not in the forefront, and how the EMG can help and to rule that in. So again, with the Halloween theme, that was one of Rod Serling's sign-offs. Thank you and good night. So was any kind of feedback or any kind of questions, similar experiences that you want to, questions you want to talk about from the case or from things that you've seen in your work with radiculopathies or things like that?
I really don't have a lot of experience, to be honest, John, to lean on. I do have an interesting case that I actually had a patient that fell off a tractor, landed on her lower legs, and had a tibial plateau fracture, and also ended up with foot drop. Right. I'm gonna go back and look, because I didn't get to do the EMG. It was done before she got to me, but I'm certainly going to go back and study that and look a little bit more. We have done a little, did some neuro ultrasound on the area, and I could find some area of the nerve, as it's coming off there. So, but like I said, definitely it's going to open my eyes, and I'm going to go back and see how good a study this neurologist did on her, because I don't know that he got very in depth and looked at it, because I'm not sure that he answered all the questions himself. Right.
Yeah. And so that's what unfortunately I've seen that quite a bit, where the patient may get rushed through, and you want to be proficient, but you also want to answer that. You don't want to take one test to take you 4 hours, but you want to get the test to answer the questions of why you're doing the test.
Right.
So you want to be thorough and proficient and efficient, but not, just get them in, get them out quick as possible. So but that just comes with, like any skill, with time. If you think back to your first PT evaluation coming out of school, probably took you, an hour. But now you can evaluate a patient, relatively quickly. Just with things, coming with more practice, the skill and the speed comes along.
Well, the nice thing I'll have with this is that, this is a gal too that, if he did not do enough in study, I may be able to bring her back in and do some more study on it. Cause her question is the nerve ever going to come back?
Mm-hmm.
And that's a question that of course hasn't been answered for her.
Right. Mm-hmm. Yeah. And you can tell that with the prognosis, the level of axonal damage gives you the prognosticator. If there's more axonal damage, axons in the periphery do grow back. They just take a lot longer time.
Correct.
So if you're able to demonstrate that that there's myelin injury, even may it be severe, it's a better chance for improvement versus if it's axonal. It's going to take, even assuming normal medical health and metabolic health, it's going to take that about the recovery rate is about an inch a month or a millimeter a day.
Yeah, correct. Her only benefit that she's got really is that actually it's not that far from the fibular head to her tibialis anterior. So,
right. Mm-hmm.
Yeah.
Mm-hmm.
Okay. Very good.
Comments or questions or thing you want to discuss, or cases you want to bring about, or something you want to bring up?
I don't really have anything right now that I could think of.
Okay.
I'm just taking it all in, listening.
Okay. Have you seen patients like this where you may start down one path and then while you're something you pump something goes, hey, that doesn't fit with the picture that I was thinking of, and then I have something else I got to look at. So
I feel like it happens more than often than not.
Yeah. Right. Mm-hmm.
And the next thing you know, you're doing more tests and more checking, and
Mm-hmm.
it just keeps evolving.
Right. Mm-hmm. Good. Well, was this helpful for you guys? I mean, it was a little bit, like I said, a little bit review, a little bit, twist.
No,
a little,
very good. Excellent.
Yeah, I agree, John. Even though I don't have the experience that Laura's got, just looking at how you break it down was very good.
Good. Okay, sounds good.
Even at my level where I'm at right now, you were able to give me pieces where I could put the pieces of the puzzle together and come to the outcome thought process, more like I should. So that was good.
Cool. All right, sounds good. All right, so I guess I'm going to go through my son's candy now that he took before he goes to bed. I'm going to pick out my favorites, and I'll leave him with the ones that I'll tell him he likes, and we'll take it from there. So if you guys have, you can feel free to email me anytime, and even if I may not be your mentor directly, I can always ask any questions you may have, and I hope to help you along with this process.
Well,
great.
John, I certainly, I would be glad to do that anytime. I like the way you break it down, and you definitely do a good job to help us think.
All right, cool.
Yeah, and I just found out that you're my mentor, John.
Okay.
Did not know that.
All right. So sounds good.
All right.
So, but I appreciate your help. That was great. I enjoyed that.
All right, sounds great. All right, well,
I'll
probably be seeing you guys around soon, and if not to see you, then I'll see you via email or electronically.
All right, sounds good. Have a good night.
Yep. Thanks.
All right, good night.
Good night.